Good afternoon, everyone. Welcome to the plenary session entitled Pandemic Prevention, COVID-19, Emerging Infectious Diseases, and Other Communicable Diseases. Actually, this reflects really the theme of the entire meeting. It's one part of it. As you know, our overarching theme of this meeting has been global health at a crossroads: equity, climate change, and microbial threats. In a way, we'll be touching on all three of those, but the primary emphasis is going to be on microbial threats and what they mean to us today, what they meant over the last 3 years, and the future. Where are we going? Are we prepared for the next pandemic? Obviously, our world is globally connected, and an emerging threat that occurs in one remote area of the world could, within 24 hours, disseminate to any other area of the world or to the whole globe itself. We need to be prepared for this, and that is the main topic that we're going to address in an hour and a half. Thank you very much for coming. This is, for me, the highlight of this meeting, and I just want to make a few introductions. I'm Tom Quinn. I chair the Center for Global Health at Johns Hopkins University, and I had the fortune of really reporting to my boss, Tony Fauci, at NIAID for over 40 years, where I served a role of Associate Director for International Research in the Division of Intramural Research. My co-moderator is my friend and colleague at Johns Hopkins. She is the Associate Dean of Global Affairs for Johns Hopkins University School of Nursing. We have assembled 4 of the leading experts in this realm of microbial threats. To lead off is Dr. Anthony Fauci, who really needs no formal introduction, but let me just say he's the former director and presidential advisor on COVID-19, former director of NIAID, National Institute of Allergy and Infectious Diseases of the National Institutes of Health. He'll be followed by Nicole Lurie, who is the executive director of the Coalition for Epidemic Preparedness Initiatives, CEPI, as it's well known, former Assistant Secretary for Preparedness and Response in the Department of Health and Human Services. Following Nicole's presentation, Tom Inglesby, who is the director of the Johns Hopkins Center for Health Security at the Johns Hopkins Bloomberg School of Public Health, will present. And he will be then joined by Caitlin Rivers, who's a senior scholar at the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health. Before I turn it over to our first speaker, I ran across this just recently, and I want to give a little highlight to a statement that the United Nations Secretary General just made at the end of 2022. The COVID-19 pandemic has so far directly or indirectly cost the lives of over 15 million people across the world. But it did more than that. Global health systems were overworked, overcrowded. Essential health systems were disrupted, posing major threats to the progress of the fight against other deadly and communicable diseases. In addition, an estimated 150 million children miss more than half of their in-person educational face-to-face efforts over a 2-year period, really totally disrupting the educational systems throughout the world. But women also were disproportionately affected by the lost jobs, unpaid but increased burden of work, and actually increased domestic violence, as has been documented. So this is an excerpt from the UN Secretary General putting COVID-19 in a realm of where it touches just about every aspect of life. And I am sure many of you witnessed it, felt it, experienced it, and are in fact still recovering from that. But without further ado, you don't want to hear from me, you want to hear from Dr. Anthony Fauci. So he will be our first speaker, and as I mentioned, he served as director of the National Institute of Allergy and Infectious Diseases from 1984 to 2022. He's a key advisor to 7 presidents on global HIV/AIDS issue and on the preparedness against emerging infectious disease threats. He has served as the chief medical advisor to our own President Joe Biden. Dr. Fauci was one of the principal architects of PEPFAR, which you heard much about this morning, the President's Emergency Plan for AIDS Relief, which has saved more than 25 million lives throughout the developing world. Probably the greatest movement in health substance that has been delivered in our lifetime or in history. Dr. Fauci is a member of the National Academy of Sciences, National Academy of Medicine, the American Academy of Arts and Sciences, and many other professional societies. Too many to list. He's received numerous awards, including the Presidential Medal of Freedom, the National Medal of Science, and the Mary Woodward Lasker Award for Public Service. He has already been awarded 58 honorary doctoral degrees from universities across the United States. And I am sure there's several more that will be coming. So without further ado, please welcome Dr. Anthony Fauci to the podium.
Thank you very much, Tom, for that kind introduction. As I think the first slide, oops, there you go, wait a minute, it goes back one. Okay, so as you've heard from Tom, the theme of the discussion of all of us will be emerging infections and pandemic preparedness. So I'm going to talk a little bit about lessons that we've learned from this extraordinary experience that we've all had over the last 3 years plus with COVID. But before I do that, I want to just set the background about emerging infectious diseases and put it into some historical perspective. As shown in this really classic treatise from William McNeill and Banjara Diamond about plagues and peoples and guns, germs, and steel, that pandemics have been with us before recorded history, as shown here when you look at some of the plagues that we did not know what the underlying pathogen was, obviously because the germ theory had not yet been established at that point, and only retrospectively did we learn this. But historically, the toll in morbidity and mortality for our planet has been extraordinary, and civilizations, as shown in Jared Diamond's book, have really been formed essentially by the responses and the impact of pandemics. The progress in control of this has been extraordinary. First, we recognize that microbes cause serious diseases, improvements in sanitation, hygiene, and vector control, discovery and development of antimicrobials, vaccines, and advances in detecting and monitoring. And so what the result was, when you look in the United States as a prototypic example of the crude infectious disease mortality rate, as you can see, it dramatically goes down, except for that highly recognizable peak in 1918, which we're all very familiar with. But because of this decline, a number of people, usually rather sage people with a lot of experience in infectious diseases, were out there showing and saying that, in fact, the era of infectious disease is over because of the things I showed you on the fourth slide. But as we all know now, painfully, that could not have been more untrue. I first became aware as a person who was involved in science, medicine, and infectious diseases during the early years of HIV. And I've shown this slide at previous discussions, but I want to show it again, mostly because my friend Tom Quinn liked this slide so much, he actually asked me to show it again. But this is a slide that I have shown multiple times. The first testimony that I gave before the United States Congress in 1984, and I put down the beginning of what would be the history of emerging infectious diseases, and HIV was the one we were concentrating on. And as I've told many of my colleagues, over the years, I would add one, sometimes two, sometimes three new emerging infectious diseases to the map. And when I walked out of Building 31 on the NIH campus 3 months ago, this is what my last slide looked like. In essence, all of these were new emerging infections or re-emerging. Some of them were curiosities, but some of them have had profound impact on global health. In my tenure alone, if you look from the early 1980s to 2023, or in this slide, 2022, when I stepped down, these were the emerging and re-emerging infectious diseases that we had to deal with. When I say we, I mean all of us, not only in the United States, but globally. Which brings us now to the discussion of what I'd like to talk about, namely this new novel coronavirus, which emerged from central China in December of 2019 and was originally put on a public database, which was really good. And very soon after the public database showed the sequence, we realized that it indeed was a novel coronavirus. And if you put it into the phylogenetic tree of coronaviruses, you see something very interesting that we didn't fully appreciate early on. The human coronaviruses are in red font. Those in the alpha and around 8 o'clock in the beta coronaviruses were the common cold coronaviruses. I'm going to get to that in a few minutes because that really tells us a lot about what one could have expected if this turned into a pandemic. And then we had SARS-CoV-1 and MERS, and then you see in the yellow block SARS-CoV-2. Fast forward from that phylogenetic tree, which we put together in the very early weeks of the pandemic, to where we are now, a global pandemic the likes of which we have not experienced in over 100 years, with close to 800 million reported cases globally, much, much more than that in reality. They say about 7 million deaths. It's probably closer to 15 to 20 million deaths. In the United States, the number of cases is probably a gross underestimate. How many people in this audience have gotten infected, mildly symptomatic, did or did not go on Paxlovid, but didn't report it to anybody? I would think most of the times we've seen that. There you go. All right, me too. Reported deaths were over 1 million. So what I'm going to talk about, and I'm going to go through this really quickly because I want to stay on the allotted time, 10 quick lessons that we've learned over the last 3 years about COVID. The first prevailing lesson is expect the unexpected. This virus was very unusual, the likes of which we've not seen. Namely, it was a highly mutable virus that evaded immunity and came in waves of different variants. And different variants really were not seen. I mean, you could go from one season to another and see a different flu virus, but not in the same season and in the same outbreak. And this is what we saw if you look at the family tree, the original Washington strain, the original ancestral strain, all the different variants, and then we got surprised in November of 2021 when Omicron came and was so far different from everything else that the immunity to previous infection essentially became meaningless for infection and partially effective for severe disease. And since that Omicron surge that went way out off the map, everything else that we've seen are sublineages of Omicron. And in fact, looking at it in a different way, it was a stepwise increase in growth capacity with a new variant that eluded immunological responses. So having said that, how do you address these new variants? One of the ways of not doing it is to play whack-a-mole, because we would have played whack-a-mole now 6 times already, and I think that would not have been appropriate. However, even though the vaccines and prior infection, although they are not as effective in the Omicron sublineage against infection and therefore transmission, it has clearly maintained a significant degree of protection against severe disease. However, we should not be complacent, and we should be aware that we might have this coming down the bowling alley of looking the other way and a new variant taking us by surprise. Don't want to be pessimistic about things, but let's not forget that that's a possibility. Next, something that I think was a real game changer for us because it broke the paradigm of respiratory diseases. 50 to 60% of all transmissions were from an asymptomatic individual to an uninfected individual. We've never seen that amount in any other respiratory infection, and it turned over the paradigms of contact tracing, mask wearing, ventilation, all the things that we didn't get completely right early on in the outbreak. The other is aerosol transmission. Again, something that took a long time, too long, for people to fully appreciate. Lesson number 2, when you're dealing with a potential pandemic, act early and rapidly with interventions, because as you can see on this slide, it's linear for a while, but then it becomes exponential. And once it becomes exponential, it really is too late for many of the interventions that would have been much more effective early on. For example, now the G7 has put forth what we call the 100 days mission. In the first 100 days of pandemic threat being identified, you get interventions going out. Third lesson, global information sharing and collaborations are essential. I don't really need to tell the audience this, that if we had been able to essentially share all information, on this slide I show what is being done pretty well, sharing reagents, sharing isolates, sharing a variety of other information. But transparency early on, which we did not have to the extent that we wanted it, would have been very helpful. Lesson number 5, using and leveraging existing clinical trials infrastructures. Many of the infrastructures that were put together early on by the NIAID, among others, for HIV/AIDS, the HIV Vaccine Trials Unit, the HPTN, the ACTG, the Infectious Disease Consortia, all of that was leveraged and converted literally overnight into a clinical trials apparatus for COVID vaccines, referred to as COVID-PN, or COVID Prevention Network. Lesson number 5, science, science, science. Prior scientific advances enabled a rapid countermeasure development. I outlined this in a perspective in Science, in which I said, and you could read it there, that the things that were going on underneath the radar screen, out of sight, out of mind, were just fundamental basic science that led to us being able to literally start making a vaccine within days, and I'll show you that in a moment. Vaccine development, you could look at it conveniently into 2 separate elements: vaccine platforms and vaccine immunogen. The platforms that we know so well, live attenuated, killed, recombinant, et cetera. The vaccine immunogens is what particular pathogen you're dealing with. In those 2 areas, scientific advances were breathtaking. First, the now iconic findings of Drew Weissman and Katie Carrico. If you look at the date on this immunity, it's August 2005. So this didn't start in January of 2020. They were able to show by modification of an mRNA molecule, you can actually make it a good vaccine platform. Next, the immunogen. This work emanated from the Vaccine Research Center at NIAID were a group of individuals that were originally brought together to make an HIV vaccine, partnered with others within the group. And I've circled Bonnie Graham here, which I hope you all know who he is, and Peter Kwong. Peter was a structural biologist trying to get the right conformation of the HIV envelope. And he and his colleagues published elegant papers, this one in Nature, showing with structure-based immunogen design, you can stabilize an immunogen, in this case the envelope, to be a very good immunogen for HIV. However, it so happened that Bonnie Graham was very interested in respiratory syncytial virus, and he found out that if you stabilize the highly immunogenic F protein in its pre-fusion form, which was much more immunogenic than the post-fusion form, he found very clearly that you had a very immunogenic product. So when MERS came along, look at this beautiful step-by-step scientific progress. When MERS came along, they were trying to make a vaccine against MERS, and they found out in 2 years it took exactly what the mutations were to stabilize the spike protein of MERS in a form that was highly immunogenic. And so, when SARS-CoV-2 came along, they used the same mutations and literally overnight, and I mean overnight, in days, were able to create the SARS-CoV-2 spike protein. And if you look at the vaccines that were used by the federal government, in the middle panel is the platform, in this case mRNA, and on the far right is the S2P, which was the stabilized spike protein that was made in the Vaccine Research Center, including Jason McLellan and others, to give us that. What did that lead to? This is an amazing slide. Amazing because it is true. And that is, if you look at the vaccine development of one of the candidates, in this case, Moderna, the mRNA 1273, if you look at the vaccine was started within 4 or 5 days. In 65 days, phase 1, 130 plus days, phase 2, 198 days, phase 3, and in less than a year, 11 months, we had a vaccine that not only was safe, but highly effective. Compare that to the time to the development of a vaccine from the time we recognized, now I think typhoid is, it's gonna be a little bit exaggerated there, 107 years, 105 years. But if you look at polio, pertussis, rotavirus, and go down to the bottom of the slide, and you see COVID in 11 months, that's a vaccine that already in 1 year, from December 2020, 2 years to November 2022, has saved over 3 million lives, 18 million hospitalizations, and $1 trillion in healthcare costs. Lesson 6, priority pathogen is one in which you pick out ahead of time what you're going to make a countermeasure against. The WHO and the R&D blueprint have it. CEPI has their own set, and everyone is working on that. But something that might, in fact, be even more, I think, payback in the long run of the unknown is the prototype pathogen approach. What do you mean by that? It means you build on prior experience that you have within a given family of a microbe. So we were writing about that a few years ago. These are a couple of the papers, some that I did, but credit really belongs to Bonnie Graham and Kizzy Corbett, who've been writing about the idea that if you pick out among the 20-plus families of viruses that could lead to a pathogen of pandemic potential, about 7 of those families are much higher risk than you would expect from all of the other 20. And what you do is you go within each family and you establish some basic virology principles, assays, animal models, antigenic targets, platforms, and a variety of others to allow you to quickly respond when, in fact, a pathogen emerges in one of those families. Lesson 7, increase attention to the human-animal interface. I think we all now are fully appreciative of the fact that One Health and understanding 75% of all the emerging pathogens come from a zoonotic source, namely an animal reservoir in jumps species. The examples of that are plentiful. Influenza birds, influenza pigs, SARS bats, Nipah bats, and on and on. This is something that is inevitable, that when you have an animal-human interface, you're going to have jump species. And this is what we now know with accumulating evidence, even though we keep a big open mind about the origin of this, the accumulating evidence, not the tweets, not the things that go around, but the evidence is now accumulating that this is a natural occurrence. And in fact, just this past month, the coexistence in environmental swabs of DNA from raccoon dogs and RNA from the virus make it clear. So how do we address that? You reduce the risk of spillover by any of a number of methods. First of all, you expand surveillance. You stop clearing and degrading the tropical, subtropical forest. You improve the economic security of people so they don't have to bring things into markets. You enhance biosecurity, and you shut down, which did not happen in Wuhan, you shut down or strictly regulate wildlife markets. Moving along, lesson 8, health disparities become flagrant when you have a pandemic. And we know that. The long-standing systemic health and social inequities are due to discrimination, healthcare access, occupation, lack of education, housing with multi-generations in families in a single house. Very, very difficult when you're dealing with COVID. Lesson 9, again, I know a little bit about this. Misinformation is the enemy of pandemic control. I don't need to spend any more time on that. I think you're all familiar with that. Lesson 10, and this is my favorite ball player ever, Yogi Berra, it ain't over till it's over. So let's look at COVID, and then we'll end in a minute by looking at what we have for the future. So for COVID, what is the end game for 2023? Well, if you look at a pandemic and the different phases of it, I conveniently, and this is one of many ways you can look at it this way. Ask the question, are we going to eradicate COVID? I can easily answer that. The answer is no. And the reason we're not, because we've only done it with one virus, and that's with smallpox for a good reason. One, smallpox is phenotypically stable. The smallpox that killed the Egyptian pharaohs is the same smallpox that we eliminated in 1980. Number two, the immunity generated by infection and vaccine is measured in decades at least, and likely for a lifetime. Now, are we going to eliminate it? Namely, are we going to do with it like we've done with measles and polio in this country? The answer is unlikely. Why? Again, measles and polio are phenotypically stable. I got infected with measles when I was a child. I was born before the measles vaccine, and that's the same measles that is now circulating in some countries that haven't eliminated measles. Next, as we all know, vaccine and infection-induced immunity lasts for decades and sometimes a lifetime. Compare that to SARS-CoV-2. One, we know from sad experience with variants that is genotypically and phenotypically very diverse. We've already had 5 and we're working on 6 variants. We don't have, unfortunately, shame on us, a widely accepted vaccine program. Only 69% of our population is vaccinated, and less than 20% have received the BA.4/5 boost. And finally, to our great dismay, the vaccine and infection-induced immunity is measured not in decades, not in years, but in months. So what can we hope for? Control. What do we mean by control? Well, some people call it return to normalcy, endemicity, making it like other viruses. That's going to require, and you've already heard just today or yesterday, that the FDA now is talking about boosters that will be given on a regular basis for the general population. But even in the spring, for the immune compromised and those who are elderly with underlying conditions. So getting down to the end of this, this is an article that I wrote just a few months ago in the New England Journal of Medicine, and it was a play on the original slide I showed you. It ain't over till it's over, but unfortunately in our chosen field, it ain't ever over. Because emerging and re-emerging infections, as I showed you on the first 3 slides, have been with us forever, before recorded history. We've unfortunately experienced several in our lifetime, and in fact, as I said in this article 15 years ago, emerging infections are a perpetual challenge, and the only way you address a perpetual challenge is by perpetual pandemic responsiveness and preparation. Thank you.
Wow, thank you so very much for those that wonderful overview and insights. And I know I speak for all of us how deeply appreciative we are of the incredible contributions from your career. So thank you for being with us today. And it's now my pleasure to introduce Dr. Nicole Laurie. As Tom mentioned, she's the Executive Director of CEPI and the former Assistant Secretary for Preparedness and Response at the Department of Health and Human Services in the USA. She has had an illustrious career and with a wealth of experience and expertise that is relevant to this plenary session today. She started her career, her bachelor's in medical degrees at the University of Pennsylvania, and then a Master of Science in Public Health from UCLA, where she was also a Robert Wood Johnson Foundation clinical scholar. She initially practiced primary care medicine and had an academic career in medicine and public health at the University of Minnesota, where she was the Director of Primary Care Research, Director of the Division of General Internal Medicine, and she served as a medical advisor to the Commissioner of the Minnesota Department of Health. From there, she became the Principal Deputy Assistant Secretary for Health in the U.S. Department of Health and Human Services. And in this role, she worked on the Healthy People 2010 and initiatives to reduce health disparities, as well as pandemic influenza planning. She next served as a senior natural scientist and the Paul O'Neill Alcola Professor of Health Policy at the Arlington, Virginia-based RAND Corporation, where she directed the organization's Center for Population Health and Health Disparities and oversaw its work on public health and preparedness. And then, during the Obama administration, Dr. Lurie returned to HHS as the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. And in that position, Dr. Lurie oversaw the federal public health response to various health crises, including Hurricane Sandy and the Boston Marathon bombing. So she's received many awards and was elected to the Council of the Society of General Medicine and is a member of the Institute of Medicine. And please join me in welcoming her to the stage.
Thank you so much for that lovely introduction, and it's so incredible to be back in a room with Tony after this time. I just want to share one thing, that after many years of doing clinical medicine and health services research and health policy, and having the opportunity to serve as the ASPR, when I went to say goodbye to Tony at the end of my term as ASPR, the one thing I said to him is, Tony, you made me fall in love with science. Finally, after all these years of medicine, I totally fell in love with science doing that job. And for that, I'm forever grateful, Tony, as well as all of your other contributions. I serve as the Executive Director for Preparedness and Response at CEPI, just for the record. And I thought I would do 2 things. I would tell you a little bit more about CEPI and its history, because I suspect it's not familiar to many of you. Talk to you a little bit about, as Tony did, some of the perspective of the last couple of years, and then I think really try to end by talking about some lessons and implications for universities involved with global health, since I think that's why you're all here. So CEPI, the Coalition for Epidemic Preparedness Innovations, was formed as a lesson learned, I think many of you know, from the 2014-2015 Ebola outbreak, where there had been a vaccine sitting, in a freezer in very early stage development for over a decade, which we discovered in our search for something to deal with Ebola during the time I was ASPR, came out of the closet, ended up being trialed and successfully used finally to end the outbreak in West Africa. But it was clear to everybody that a much better approach at the time would be to take vaccines for pathogens of great concern, as Tony said, the ones that the WHO might have termed priority pathogens, or the Africa CDC now as priority pathogens, develop them to a point, maybe phase 2, maybe not, and then hold on to them until you had an outbreak with an idea that you would be able to try them or use them to end an outbreak. CEPI was formed with that in mind in 2017, formed and originally funded by about 9 countries, the Gates Foundation and the Wellcome Trust. It started work on 5 of those core pathogens on the WHO priority list, including Lassa, Nipah, MERS, Rift Valley fever, chikungunya. And we were kind of moving along with development of all of those pathogens. And I had just finished, actually, our very first version of an outbreak response plan when, at the end of 2019, we started hearing all these rumors from China. And we all know how that story ends. But I'll say, we came back from Christmas and New Year's break and those very early first days in January, having been hearing rumors that this was a novel coronavirus, called up the developers who were working on MERS vaccine in particular and said to them, we're hearing these rumors, we don't know if they're true, but if they turn out to be true, when the sequence is posted, we would like you to stop working for right now on MERS or the platforms you are working on and pivot to working on this new pathogen. We'll work out a contract with you in a couple weeks. Don't worry about that, but please trust us and do that. And so with that, we were sort of transformed. And by April 23rd or so, we had contracts in place with several developers. And around that time, we had also had a call from NIAID and from Moderna that said, given the way the U.S. government is put together, there's not a budget line that we can use, we can sort of legally use to fund some initial clinical trial material. Can you do that? Thankfully, all the basic science work had been done. We said, of course we can do that. And that got going and accelerated the timeline that Tony showed you about getting that phase 1 material done. And then the U.S. government picked up, after that. Fast forward a couple months further, when it sort of dawned on us that the world isn't put together the way the U.S. government's put together. In the U.S. government, the government has responsibility for funding and doing basic science, for funding and doing advanced development, for making the vaccine, manufacturing the vaccine, buying it, creating a market through a stockpile or through using it, and then buying it and delivering it to the American public. Well, if you look at how the world is put together, there is no entity that's clearly responsible for any of those things. And so here we were supporting development of vaccines and then had a bunch of contracts in place. We said, no, wait a minute. Who is going to pay a company to manufacture this vaccine when we don't know if it's going to be needed? Who's going to buy the wrong materials? Who's going to turn on and scale up their whole manufacturing supply? And here we had high-income countries, the US, the UK, the EU, others, making contracts for vaccines that didn't yet exist in case they were needed to take care of their populations. And there was no entity that was responsible for doing this for the world. So we ended up getting together with WHO and Gavi, the Vaccine Alliance in particular, and CEPI, and then UNICEF, and forming what was then became known as COVAX. And COVAX initially was created as a way to sort of buy down risk, to invest in more vaccine candidates than we would need and that any of us could afford in case something worked. And obviously, thanks to so much of the work that Tony talked about, lots of the vaccines worked. But it then became a vehicle to buy vaccines and distribute them to the world. And at this point, nearly 2 billion doses of vaccine have been distributed to low and middle income countries, very consistent with CEPI's initial missions to create a situation in which there was really equitable access to vaccines. Obviously, it wasn't all that smooth. You know, low and middle income countries got vaccines way, way later than high income countries, et cetera. Over time, I think there's been sort of a lot of catch up, and I'll talk a little bit about that in a minute. But coming out of this, I think we all said to ourselves, and Tony alluded to it, it was amazing that we developed vaccines in under a year, but a lot of people died in that year. And we ought to have a really different kind of ambition to develop vaccines in 100 days. And from that came this 100-day mission that the G7 has adopted, that the American Pandemic Plan and others have adopted, that from the time a pathogen is identified till the time that it's ready for authorization for use should be 100 days. And that during that time, you got to do things like turn on the manufacturing, scale up all the systems, get ready to deliver it. Now, how on earth can that happen? Well, Tony talked about that, I think, in his talk, and really started to think about this approach of prototype pathogens, looking at the viral families, and this is really an idea that first started at NIAID and then has been really embraced by much of the world. So to invest in developing vaccines and platforms and all the enabling sciences that support that for a bunch of viral families, with the idea that when something happens, you can build from the viral family and the platform that is most suitable for making that vaccine to a vaccine quickly, and that you know enough by that time about the platform and its safety, like we know about mRNA, like we know about some protein subunit vaccines, et cetera. You know enough about the platform, you know enough about the viral family, and you know enough about the immunology that in a bad situation, you're pretty comfortable moving forward with early deployment of vaccine at 100 days while you move forward with trials, collect the real-world evidence, the other things you need. The other thing that we said is, gosh, you know, manufacturing of vaccines really needs a step change, and it needed a step change in two ways. One is manufacturing just takes way too long to go from making a vaccine to getting it into a vial and release. And a lot of that is in getting not making the vaccine in bulk, but getting it into vials and syringes. But the whole thing just takes way too long. And most of the vaccine manufacturing is concentrated in the global north. And there was a gigantic need and shortage in the global south. And if every country's leader has an obligation first to take care of its own citizens before letting vaccine go, you have a setup for terrible inequity. And scarcity is the enemy of equity at the end of the day. So another goal has really been to think about step changes in manufacturing and building distributed manufacturing capacity around the world so that you're not dependent on the manufacturing capacity in one or two countries. And as much as now we talk about this 100-day mission and we're excited about the 100 days, I don't think we can forget that second 100 days for 1 minute. That second 100 days is when the manufacturing has to scale up, and the second 100 days is when you have to have all the systems in place to be able to deliver and administer vaccines to populations around the world. That second 100 days has to start in the first 100 days, but I don't want anybody to come away with the idea that at the end of 100 days, we're going to stand there and say mission accomplished. So just wanted to note that. And so CEPI is now in its second 5 years, what we call CEPI 2.0, and we're focusing on, first of all, getting across the finish line with our core pathogens, and I think the one that's closest is a chikungunya vaccine that I expect will be licensed in the next couple of months. The other vaccine that's getting pretty far along is the vaccine against Lassa fever, which is endemic in West Africa, and for which there's a lot of real excitement. So getting those across the finish line, making progress with the viral families, and making progress on the manufacturing end, and then the other piece, which I started with, is what do we do about the way all these organizations in the world are put together? We have no idea who's responsible for what. There's not, in a crisis, a way to finance all of this. All these organizations spent probably 50 to 60% of their time through this experience passing the tin cup, trying to raise money, right, to develop vaccines, to manufacture vaccines, to buy vaccines, to distribute vaccines to the world. We take this system in the US really, really for granted. We shouldn't do that, but we gotta rationalize the system for the rest of the world. So I just wanted to share those perspectives. I want to shift for a moment and also say, not only did I take the experience of how the US system is put together way for granted before I started working at CEPI, I've been really caught off guard by what working internationally has been like through this pandemic and beyond. And I think that there are a lot of implications for all of us that work in universities and schools of public health. First, I'd say that the dynamics between the global north and global south are very, very difficult. I know that we all know this, and we know this intellectually. But particularly coming out of this pandemic, I would say, as a generalization, the global south is very resentful about what happened in COVID and the long delays in getting vaccines. They see this as, and it probably is, a vestige of colonialism, and the global south doesn't really want the global north telling them what to do. So we're all here in Washington trying to operate in an environment where a lot of the world feels really used by us, and that there is enormous distrust of the US and many high-income countries in the global north, especially after COVID. Now, some of it has to do with COVID, some of it has to do with our prior administration, but I think that there are a lot of historical roots, even in the way we have done or collaborated with scientists in the global south over time. And that is changing, and it's been changing slowly over time. But just like manufacturing needs a step change, I'm going to argue, I think that this needs a step change. Having said that, I think we've got to acknowledge we did some pretty terrific things in COVID, right? The United States manufactured and bought huge amounts of vaccines that were donated through COVAX to the global south. But, you know, they were mRNA vaccines that required an ultra cold chain and that got there too late. So you can see like the real advantages of what happened. You can see a lot of the disadvantages of what happens. And I think we just need to all learn and move on from that. The other thing that I think we all could think about is how it is that we do a better job at the front end thinking about equitable access. So when CEPI engages a developer and signs a contract with a developer, and we did this in COVID, and it's how we got the first vaccines out there, part of the contract is about equitable access conditions. And when we started, the conditions were, we would like you to be able to reserve a proportion of your vaccines for low and middle income countries, and that we can delegate the availability of that vaccine to some entity that's going to make it available for access, for equitable access. And it has to be priced in a way that low and middle income countries could afford it. And so we do that with every single one of our contracts. The first COVID vaccine that made it across the gate for us was the Oxford AstraZeneca vaccine. And as you know, that ended up being a not-for-profit vaccine. Millions of doses got delivered to the world, and probably many more would have been able to do that had, India not exercised export control and kept that vaccine from flowing through COVAX. But I think we can think up front about how we do equitable access differently. When taxpayer-funded research is involved in making vaccines or making products like this, should they come with some equitable access commitments when you fund a manufacturer? When you're at a university, the incentives at the university for many of you, and especially in science, are to get patents and to get the IP, and the university gets really rich from the IP, and it's one of their sources of income. For all of us who are working in these areas where we might make products for global health, is there a different way to conceptualize this? I'm not saying give up IP, but is there, and that's a really controversial issue, and I don't want to get into it here, let's put it that way. But I do want to say, is there a way that we can think really differently up front and along that whole research and development chain about how all of us contribute differently to equitable access, so at the end of the day, we don't end up with these profound global inequities that we ended up with in COVID? I think there probably is. And in the case of the US and other high-income countries, I think it's really clear that governments can take care of themselves also by taking care of others. Ultimately, that's what we did in COVID. I think that the US government's contributions to organizations like CEPI and CAVI are another way to do that. We are simultaneously taking ourselves and we are supporting institutions that are really going to act on our behalf and others to help support low-income countries, and I think that's important. Thinking a little bit more about, all the work that you will do. How's the science that you do? How's the work you're going to do going to contribute to this 100-day mission? And for many of you who are not in basic sciences, how's it going to contribute to that second 100 days? All that work on building strong healthcare systems, immunization systems and moving to life course immunization, how to mobilize communities, how to deal with miscommunication, how to help deal with the infrastructure in communities, how to work on clinical trials around the world and not just go in and build and use a clinical trial site and leave, but make it sustainable and keep it warm. All of those things are just really, really important. As you're building products, developing products at universities, how are they fit for purpose? How do you think about stuff like an ultra-cold chain or other sorts of things so that we think about some of these things from the front end as well as the back end? And I appreciate with mRNA, the science has to evolve to get us there, and it was where it was at the time the COVID started, and I think we're all incredibly grateful for it. But we have a lot of work to do beyond that. And then finally, as I know has been the topic of many other sessions for many of the countries where you work and where you have collaborations, how you think about continuing to support research infrastructure, how it is that you share power, how it is that you share credit, how it is that you share know-how, laboratory specimens, all of those kinds of things, so that at the end of the day, we can get to where we want. And so finally, all of you, or many of you, work in universities where we talked about the incentive structures for IP. We talk about the incentive structures for publication. Can we pay a little bit more to the incentive structures that help you all think about the kinds of ways in which we collaborate with and interact with scientists, public health personnel, people who live in communities around the world, so that at the end of the day, we don't have this giant north-south divide, that we can, I think, help heal some of these wounds and make progress for all of us in global health as a world. So I'll stop here and turn this over to whoever's next. Thanks.
Thank you very much, Dr. Valori. I've learned an immense amount about CEPI and the 100 days and the 200 days and its practicality to all of those here from universities and the role of universities. I would also just make the brief announcement. There's 67 countries being represented in this audience. So talk about north-south divide. I'm sure that struck home to many people. Moving on, it's my pleasure to introduce a good friend of mine, Dr. Inglesby. Tom's the director of the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health. It's dedicated to protecting people's health from the consequences of epidemics and disasters. Dr. Inglesby is also a professor in the Department of Environmental Health and Engineering, also in the School of Public Health, but he also has a joint appointment in the Division of Infectious Diseases in the School of Medicine, where we interface. His work's internationally renowned in the field of public health, preparedness, pandemic, and emerging infectious diseases, prevention and response to those biological threats. He has a long list of affiliations, serving on the board of the Centers for Disease Control, serving as chair of the Board of Scientific Counselors for their Center for Preparedness and Response. He's also interfaced with HHS, with the WHO, many other organizations. But rather than me going through a long litany of his appointments, I want to welcome Tom Inglesby to the podium. Thank you.
Okay. Great, thanks so much, Tom. Okay, what I'm going to do is propose a series of priorities around preparing for future epidemics and pandemics. Let's see, first, it looks like, can we go back to the slides? They were here a moment ago and then are now gone. Where are they? There they go. Okay, fantastic. So a few just opening assumptions, principles, and the first is that we need to use the moment that we're in now to actually take action and not just study what happened. I think most of us probably have lived in the world of after-action reports and see them written and then go onto shelves. We have a moment where policymakers are still listening in some places and can actually help us move the needle on the many things that we experienced, and so let's convert it to action. We should also think about the future and not assume that it will repeat the past. COVID is not the upper limit of what we could face in pandemics in the future. They could be different, affect, for example, children. They could affect young adults in ways that we didn't see. They could have different kinds of mortality transmission. So we need to plan broadly. Disease X has been mentioned by Dr. Fauci already, and we really do need to be planning for the response to unknown pandemic threats in the future, presumably from the viral families that have been alluded to already in both the presentations, but really focusing and getting policymaker support for Disease X programs. That's what WHO calls future pandemic threats and believes are quite probable. And Tedros himself has said a couple of times that he believes those kinds of things are in our future and we need to prepare for them. I was in an exercise only 6 months ago where very distinguished leaders from around the world really debated about what kinds of things are appropriate at the start of a new pandemic. And there was really clear disagreement in the room about schools, about social distancing, about travel restrictions, even now after we've all lived through COVID. So we need to drive towards more consensus because we can anticipate there will be lots of political debate, and the more that our technical community can really come around conditions under which certain activities would be put in place, the better we'll do. We need to budget for this work. Right now, that's not happening, in my view, in the US or elsewhere in the right way, even though the administration put forth last year and again this year a very ambitious plan for building pandemic capabilities and a budget for it. Our Congress did not take that plan up, but needs to. And finally, I think we really need to get to the business of building capacity and stop scapegoating our leaders and not go backwards and look at and avoid revisionism, which is beginning to happen around some of the successes in the pandemic, which are being undermined. So I'm just going to quickly buzz through these priorities. I won't stop here because I'm going to talk about each one of them for a moment. And the first, which is, again, I don't need to say much about this because it's already been covered by Dr. Fauci and Dr. Lurie. We need to fund and implement faster vaccine programs. Incredible success in COVID, but we all want to try and move the needle to the left. And the 100-day program, 100-day mission around the world has already been mentioned, and we need to get behind that. And that's going to take funding as well as technical expertise and partnership between governments and industry. We also need to tend to the therapeutic developments. That's not just antivirals, monoclonals, but also medications that blunt the immune response, the very damaging immune response that we saw during COVID, and be able to have the diagnostics to link testing and treatment quickly in a way that wasn't possible until we had really large-scale diagnostics on hand and treatments to go with them. And we need to really expand manufacturing capacity, not just in a few places, but regionally around the world so that we can avoid political leaders keeping medications or vaccines within their own borders. We should be able to make things concomitantly in many places in the world. That's a money problem, that's not a technical problem. And so that requires the will of political leaders to do. Next slide. Imagine, I've got it under my control. Yeah. Imagine that at the start of 2020, around the world, we had rapid testing, that we could actually distinguish who was sick from a flu or a cold and the first day of COVID. We couldn't do that for a long time into COVID. And that, again, is a technical problem that is solvable. But we need to go through a series of steps, what we would call in our center a National Diagnostics Action Plan. None of them are rocket science, but there are a series of things that have to be done both here and in other countries that have diagnostics technology and plan around diagnostics, which are connecting the government and industry together around testing and getting on the same page, setting up contracts that can be moved on quickly in the event of crisis, standardizing the way that we report data around the country. That was a real hang-up for test manufacturers and testers in pharmacies elsewhere. We have to be able to get through the FDA as quickly as possible while also obviously preserving effectiveness and safety, and have a stockpile of the kinds of reagents that kept running out and slowing down testing both in the US and other parts of the world as everyone was avidly seeking the same kinds of products. And finally, we need our public health leaders to be able to communicate quite clearly how many people are going to get tested, with what frequency, with what goals, so that the manufacturers can build against those goals. Often the manufacturers in the US and elsewhere in the world during COVID weren't sure yet of how many tests they needed to make and at what scale, what speed, with what characteristics. Early warning detection forecasting, I actually now know that Caitlin is going to cover a lot of this, so I'll just echo again and agree with the speakers who came before me about the strong importance of international partnership around early warning, around sharing of genomics information, about surveillance systems that can help us understand the extent of an early epidemic or pandemic, sequencing capabilities. There's a great article yesterday, I think, in DevX, which talked about sequencing capabilities being built in low and middle income countries, both for detection and also for variant analysis, which is exciting. And we need institutions that can do the kind of forecasting and analytics that CFA can do. I'll just give a shout out because I know that's coming. Next slide. Something that has caused all sorts of political consternation, both in the US and in other parts of the world, is the whole suite of non-pharmaceutical interventions. We should expect, we know there will be a time, and it could be a very long time in the next pandemic before we have a vaccine or a therapeutic that works. We're going to do everything we can to try and drive that time shorter and shorter. But in the meantime, what are the actions that we should be taking that public health leaders in this room and elsewhere should be advising their political leaders to take? And under what conditions? And you all live through all of these. Just list them. It's a not complete list, but there still is controversy in the world, a lot of controversy, especially on some of these things in the US and in other governments about what's the right approach. And we should do what we can to try and resolve that. On the healthcare system side, we saw the painful struggles around the world, both of the healthcare workforce getting sick in the earliest days and dying from this disease, and then their great challenge of keeping up with all of the sick people that came into the system. We need more reserve where we can build it, and there are efforts now going on around the world around building healthcare system resilience, which should be supported. We would strongly argue that part of that should be more reusable products, so that we're not all vying for the same products at the same time around the world and crushing our supply chains, which would happen again tomorrow if we had another pandemic tomorrow. We're all looking for the same single-use disposable products. So we should be moving towards a more reusable set of products in the world. We have things like nursing shortages, which are terrible on a daily basis, and we need large systemic solutions around that. And pandemics will only make them much, much more acute. And innovative workforce solutions. And public health, of course, the other part of our healthcare system. What do we need to do to build public health? We just developed and published a report around the kinds of changes that are important for CDC, having lived through the pandemic, and won't go through them all here, but CDC needs a lot of things to be ready for future pandemics, some of which are in its control, some of which are entirely out of its control and depend either on the White House or HHS or Congress or its external partnerships. And some of those are around budget and hiring and retention and operational agility, and also about how they deploy people across the country to help with state and local execution of programs. We also need stronger labs, stronger workforce, and to protect the public health leaders, some of who are right here with us, from the kind of attacks that happened throughout the pandemic. We saw public health officers around the country that were fired for saying the right thing, that were threatened in their own homes. We need to move beyond that. I don't have a solution here, but we can't let this go away without attending to it, and I know this also happened around the world. Last couple of slides here, just to echo what's already been said, which I think very elegantly by Drs. Fauci and Lori. We had profound problems with disparities, got somewhat better over time, but still continue to be a serious problem in the United States. We saw that in other parts of the world as well, and there is no single quick magic bullet solution, but there are many things we should be doing around community engagement, speaking with leaders, working with disability communities, the underrepresented, community health workers, and that work needs to go on. I will put a plug in for the work of government officials here and around the world. I think government, at least in the United States, gets a bad rap. It often is alleged to be doing too little or too slowly. The officials that I work with in the last couple of years were amazing. They know the law, they know the budget process, they know execution of programs, they understand a very large, complex federal government, and have incredible admiration for them. We also need political leaders to come in responsibly for a period of time and make difficult decisions while they're there and to move on. So we should do what we can in this community to honor public health, and I think this community instinctively does believe in government, given that public health is a governmental function in many ways. And finally, the international response, my last slide here. I think these things are all obvious to this room, but we're saying again that the World Health Organization needs to be at the center of an international response. It's the crucial organization and needs our support. COVAX was a phenomenal intervention, and I think a model to be emulated and improved upon, and I think Nikki already started to talk about that. I mentioned CEPI because it is such a critical relatively new institution driving vaccine development, and then the rest that you can see. If you don't know about the pandemic treaty discussions going on, that's worth you all attending to. If you care about these kinds of international developments, there's an effort underway right now to really strengthen national commitments to a series of capabilities, to building that kind of capability. It's going to be a very difficult treaty because so many things are sought by countries around the world, but within a year, we should have a new pandemic treaty, which could conceivably help with access and benefit sharing and building up capabilities for things like public health and healthcare systems. And lastly, I'll just close by saying thank you to all of you. This is a group of people here who, in their science and clinical trials and operations and implementation, really helped governments around the world to get through this, and the public around the world. So thank you for all the work that you all do. Thank you.
Oh, thank you so much for the really interesting talk and great thoughts about next steps and moving forward. And our final speaker today is my pleasure to introduce Dr. Caitlin Rivers. She's a senior scholar at the Johns Hopkins Center for Health Security, and she's an assistant professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. She's an epidemiologist specializing in preparedness and response for epidemics, pandemics, and deliberately occurring events. She earned a PhD in genetics, bioinformatics, and computational biology from Virginia Tech, and she also has a MPH. Her doctoral research focused on computational epidemiology, specifically modeling emergent infectious diseases. Before she assumed her role at Hopkins, she was a founding associate director of the Center for Forecasting and Outbreak Analytics at the CDC. And she's also worked as an epidemiologist for the U.S. Army of Public Health Center as a Department of Defense Science, Mathematics, and Research for Transformational Scholar. She has testified in the front of the U.S. Congress on several occasions and is a frequent advisor to state and federal levels. She served on the Biden-Harris presidential transition team working on COVID-19 policies. She's been published in a number of papers, Wall Street Journal, New York Times, and has participated as an author or contributor to several influential reports, including the U.S. Pandemic Response, National Coronavirus Response, a roadmap to reopening and public health principles for a phased reopening during COVID-19. So this guidance for governors was used by the National Governors Association, the state of Maryland, and Washington, D.C. So she's already had several awards and serves as an associate editor of the Journal of Health Security. So please join me in welcoming her.
Great, thanks for that warm welcome. I want to share with you all today a new capability within the U.S. government that I think is one of the silver linings of the pandemic. There are not many of those to point to, I will say, but the Center for Forecasting and Outbreak Analytics is one new capability that I feel proud will exist to help us to meet the mission of the next emerging infectious disease. Now, I am back at Johns Hopkins now, but I had the good fortune to champion the creation of CFA for several years prior to the pandemic, and I was able to step away from my role at Hopkins to help found the center at CDC. Now, the Center for Forecasting and Outbreak Analytics, or CFA, is trying to fill this gap. When there is a new outbreak, a new emerging infectious disease, policymakers need information in order to make decisions about what they're going to do and how they are going to implement the kinds of responses that we know are needed in the early days of an outbreak. The kinds of questions that they may have are things like, how many new cases can we expect? Where should we enroll our clinical trials to ensure that they are sufficiently powered? What kinds of interventions will be most effective given a limited set of constraints? And at the core, those are all modeling-informed questions. Now, of course, modeling is not the end-all, be-all. There are a lot of ways to bring wisdom and experience and traditional epidemiology to these questions, but modeling is a new emerging way that we can help to bring evidence to those really tricky discussions in the early days of outbreaks when there is not a lot known. Now, prior to the founding of CFA, what would happen, at least in the United States, because there were not a lot of modelers in the federal government, is that a loose coalition of academics would be called upon to step in and answer some of these really tricky questions. And that was an amazing resource and remains an amazing resource, that there are academics out there willing to volunteer their time, often completely unremunerated, often taking away from the responsibilities that they have in their day-to-day life in order to respond to these emerging infectious diseases. I'm really proud to be part of that community as an academic, and it's something we relied upon in the public health community for years. But it became clear that that wasn't enough. It wasn't working because there's such a need for modeling in the event of outbreaks. There are so many questions, there are so many decision makers, not just at the federal level, but also at the state and local level. It was really time to formalize this capacity, and that's where CFA, or the Center for Forecasting and Outbreak Analytics, came in. CFA is less than 2 years old, and a lot of that time has been spent founding the organization, really getting the building blocks assembled. But already in that short time, the organization has made contributions that I am proud of. I remember very clearly over a Thanksgiving break, November, in the United States, our colleagues in South Africa made the world aware of a new variant, the Omicron variant, that was causing a surge there. And the Monday after Thanksgiving break resumed, CFA convened our academic colleagues, told them that we were concerned about what this new variant might mean for the United States, and asked them if they had anything on the shelf that would help us to understand what the impacts would be in the United States. And then with just a couple days, we had a better sense of the kind of wave we could expect in the United States. And we were able to bring that information, including numbers, including charts, to federal officials to help them to understand what was coming. And that several weeks of advanced planning allowed the gears to turn faster, allowed decisions to be made that otherwise may have fallen in the wait-and-see category. CFA has also contributed to decisions around boosting and vaccination, later to the mpox or monkeypox outbreak. And so even in these really early days with just a handful of employees, it's bigger now, but when I was there, we were a very small cadre. We've been able to contribute to public health decision making in a way that I think is really substantive and really exciting. But what I think is especially exciting is it's not just US CDC. There are similar capabilities established or being established in the UK, with WHO's new Berlin hub, and I know of several other countries that are working on establishing similar capabilities. And I think it would be really exciting if we were able to grow a network of centers doing this kind of work around the world. I think it could really become greater than the sum of its parts and contribute to the kind of fast, effective decision-making that we know turns the dial on public health. Now, since this is a conference of educators, I'll just highlight that in order to realize this vision of having a robust network of people who are fluent in modeling, in data science, in computational epidemiology, and really plugging them into public health practice, we need to do more to raise the kinds of public health professionals that have those skill sets. In my experience, modeling is not taught widely across schools of public health, nor is more advanced data analysis using programming languages, for example. Now, there are exceptions, of course, for your students in biostatistics. Those may be the kinds of courses they pursue. But I think there's an enormous opportunity to bring those skills to more students and help them recognize that this is a really exciting and growing area of public health. Now, one of the things that I'm proud of at CFA, and I meant to say this earlier, but it's not just modelers. It is not just modelers at CFA. There is also about 1/3 of the organization devoted to research and development because we recognize that pushing the boundaries of the field is important, but the last third of the organization is actually devoted to communication. I think this is huge because we've seen over and over again, not just in COVID-19, not just in mpox, but throughout all of public health, that communication is often where things fall through the cracks. You can have the best model, the best analysis, the best advice, but if it's not reaching the people who need it, then it's not going to be implemented in a way that matters. And so about 1/3 of CFA will be devoted to communicating the modeling and analytical results. Now, what does that say about what we need to do as educators? We need to push communication. We need to make sure that our students are ready to enter the world as public health professionals with the capacities and the skills to communicate to senior leaders, to state and local leaders, to the public. And we need to make sure that that really touches all areas of our coursework and does not just reach the small number of students who may know early on that they want to enter communication. I can say many of my modeling friends after 10 plus years in this field did not think they would ever be doing communication, but come to find out, nobody's gonna be able to use your model if you're not able to communicate it effectively. So with that charge that I would love to see in the world, a network of CFA-like organizations that are able to turn data into models, into analytics, into public health practice, and that we need to be doing more as educators to bring those skills to our students so that they can really help this field grow. I'm really excited about the opportunities that this presents for public health preparedness. Thank you.
Thank you so much for that description of the mathematical modeling, analytics, and communication. There actually was a session early this morning on the mathematical modeling of pandemics, which was really exciting and represented people from around the world that participated in that. We are getting near the end. You've heard from all four of our experts. I want to open it up to you now. There are microphones. If any of you have questions, want to enter in a dialogue with one of our experts, I welcome you to come to the microphone. It's always very hard to see with lights, but I see one. Go for it.
Hi, thank you guys all so much for your service and inspiration in the field. My name is Melissa Salm. I'm a biosecurity fellow in the Center for International Security and Cooperation at Stanford University. Dr. Fauci said that misinformation is the enemy of pandemic control. And Dr. Lurie, you alluded to distrust wrought by the global north-south divide. And Dr. Inglesby, you also alluded to controversies surrounding non-pharmaceutical interventions. But most pandemic preparedness programs overemphasize the role of biomedical research and biotechnological solutions. I have two questions. How do you decide which challenges and solutions to prioritize? And what should social scientists be researching to prepare for pandemics and threats to pandemic control?
So that's really a great question, and I think, if I wanted to put 15 lessons and added a few more, one of them would have been that we've really got to learn through the social sciences about how we can engage the community better, because the pushback that we've had for what to us appear to be and are rather classical public health measures, the degree to which that was pushed back clearly had political implications, reflecting the divisiveness in our country. But we can't just stop there and say, yeah, we have a lot of divisiveness in the country, so a lot of people didn't want to wear masks because you said wear masks. People said don't get vaccinated, even though vaccine is unequivocally safe and effective. We have to now go back and try and examine why there was such a degree of disagreement, and rather than condemning the people that disagreed and even pushed back in a somewhat aggressive way, try to understand beyond the political considerations why they didn't accept what under other circumstances would have been extremely obvious public health interventions that anyone and everyone should have embraced. So I think in addition to science that I spoke about, in addition to some of the things that Tom and that Nikki spoke about and others, I really think we need to make that a very important point of our discussion looking forward. I don't know how others feel about that.
No, I would totally second that. I mean, obviously, the issues of, early warning, the issues of science, all of those things are key. But at the end of the day, unless you have the trust of the public, you really can't do any of the rest of this. You can't get money from Congress. You can't implement public health measures, et cetera. But if you really want to think about, and we've got a ton of work to do to think about and learn about how to do this, a lot of that distrust is also rooted in the kinds of local, national, global socioeconomic disparities that exist. And there's, a huge amount in the social science literature, right, about social capital, about trust, about interpersonal connection. There have been some terrific studies now that help us understand that interpersonal trust and trust in government is essential and is one of the major explainers of the variation in outcomes both in countries and in states across the United States. And so there's a lot of science and a lot of research and social science to do. There's also a lot of public policy work to do to really think about the way our societies are put together, quite honestly, and the kinds of things that are going to help us sort of rebuild the bonds between people and ultimately the trust that is required to move forward. And then obviously leaders got to earn that trust, and we know that it can be squandered at a moment's notice, and we have to think about how to prevent that. The other thing I just want to say and just point out is that it's not just an issue here, but that there are a number of entities around the world, and we can name them, who make it their business to sow discord. And they do it through media, they do it through social media, they do it through infiltrating all different kinds of organizations, all of that kind of stuff. And just as we got early warning systems for if a disease is coming, we need to do a much, much better job identifying it, shining a light on that, and making it stop. And if I think about one of the places I think we really missed the boat at the beginning of the pandemic, in addition to many of the other issues, it was there, and I just want to call it out for what it is.
Yeah, so because there's a number of people there. It'd be interesting to hear your questions. So why don't we start there? One person there, one over there, and one in the middle here. Please try and keep your question or comment short so we can, but go ahead, starting here, and then we'll respond accordingly.
Okay, thank you. And thank you to the panelists for the very good presentations. I come from Kenya, from the Ministry of Health, and I work at a center called the Center for Epidemiological Modeling and Analysis at the University of Nairobi. So my question is to Caitlin. You touched on communication, and I'd like to get a few tips on how to communicate uncertainties from modeling, and especially to decision makers, because I'm currently also a PhD student trying to come up with models, but also the uncertainty issue is really key. What tips do you have for that? Thank you.
All right, and then over here.
Good afternoon. My name is Ricardo Leite. I'm a member of parliament in Portugal and founder president of Unite, the Parliamentarians Network for Global Health. We represent current and former members of parliaments, congresses, and senates in 97 countries around the world, working in partnership with the World Health Organization. Very interesting comments. Thank you for your work also throughout these very difficult years. We had a session with around 300 parliamentarians at the World Bank Spring Meetings earlier this week here in DC, and I asked the people in the room who of those MPs knew about the pandemic treaty negotiations. Not one hand was shown. So this is something that is very concerning, because I don't believe we'll get a treaty, but an accord in the line of the Paris Accord may be a possibility. But if we get parliaments and congresses and senates around the world blocking it, this is a tremendous backlash, a negative backlash following all of the efforts that are being made, and a lost opportunity given the pandemic we've been through. We saw the World Economic Forum Outlook report putting health emergency response at the bottom of the list. Mango production is more important than health emergency response in the minds of many politicians and political and business leaders. And so this is something I would like to hear your comments about. Regarding the accord, there are two aspects that I would also like to hear your comments, which is regarding funding. We know that we have the pandemic fund out of the World Bank that has 1.6 billion, but we need 10 billion a year at least to get the job done. And the other is accountability. We all believe that the World Health Organization has a pivotal role, but making sure that the governments are accountable is critical. And a last comment on what was said regarding the trust in institutions and trust in government. We have seen in our network that we also need to build capacity and trust among those that represent the people. We need to invest seriously through networks like ours and many others to make sure that we are building capacity with many politicians that are not global health trained physicians or academics, but will have to play an important role when a new pandemic hits. Thank you.
Yeah, thank you for that important comment. Right in the middle here.
Thank you all for the discussion, and thank you, Dr. Laurie. You mentioned a lot about the difficulties in getting vaccines to low and middle income countries. The situation seems very similar to issues in the HIV days of getting ARTs to low income countries, and it was mostly due to patent protections that prevented millions of lives from being saved. So I'm curious if you think the way forward to prevent this situation from coming again is to change international IP laws, or if there's some funding mechanism that can be started to subsidize systematically the provision of pharmaceuticals for low-income countries.
Great, and I am going to extend it one more in the middle there, and then we're going to, I'm going to have you all give your finals. Yeah, okay. All right.
Well, thank you all so much. My name is Lauren Pishaw. I'm an infectious disease doc at Yale. My question is given the emergency, like how frequently you have emergent events, how do you know when it's time to sound the alarm and be like, yes, this is an actual event where we need to bring in the 100 Days Project? And are you worried at all about, quote, crying wolf and bringing everyone together and then something not happening?
Okay, it's up to you folks now. So starting with Caitlin.
All right, well, it's great to hear it's not coming on. It's great to hear of a sister organization in Kenya. I hope you'll write to cfa@cdc.gov to make sure you're connected to this brand new network. But I don't know about tips, but I take a lot of inspiration from the National Weather Service. 10, 15, 20 years ago, storm warnings used to say barometric pressure is falling, and nobody knew what that meant. Nobody did anything. It was a curiosity. But now if you look at the storm warnings, they say things like small trees will be uprooted, windows will be broken. This is life-threatening storm weather. And the reason that they changed their messaging from here to there is because they researched it. This gets to the social science question. If we want to be able to improve our communications, both for modeling and for public health practice generally, there's a lot of opportunity to research how to do it better. Some people do it, not enough.
Well said. That's great. Maybe I'll try to address a couple of these. To my colleague at Unite, thank you for all the work that you continue to do. It's really, really important. You know, the Framework Convention on Tobacco took, 10 years, 12 years to pass? I'm really impatient, as are you. I think it's going to be a long haul on the pandemic treaty personally. And I think it's really incumbent upon us not to put all of our eggs in one basket, but to think about all the other ways in which we can make a ton of progress at the same time. Even now as we speak, the organizations that form COVAX, WHO, CEPI, UNICEF, Gavi, are meeting every week to say, how should we work together in the future? What changes can we make now so that next time we're going to be in a much better position? Yes, ultimately it should dock into the pandemic treaty. Yes, ultimately it should dock into someone's notion of how the whole world should be put together. But for right now, let's put our heads down and figure out what we can do. And maybe just to the questioner about when do you know that it's time? I think my own philosophy is you take that on-ramp really early and you take the off-ramp as soon as you can. You can never make up for lost time. And if it's a government's responsibility to protect its people against bad things happening, you need to start early. You also need to communicate what's the return on investment for starting early. The worst, if we spent a few $1 million and got countermeasures ready and it turned out that we didn't need them, we would have advanced science. We would have stabilized an economy and a stock market, which might otherwise have crashed. And we would have had a lot of other collateral benefits. The more you practice, the better you get. So my own belief is you always start early and you look for that opportunity to stop as quickly as you can.
Great. I'm not sure if this works. Should we just keep going down this? And then we'll let you. Does this work? Okay. So to the question from our colleague parliamentarian, I thank you for the work that you're doing. There is no easy way to get governments activated. I think parliaments, political leaders speaking to the representatives that go to Geneva and that interact on these kinds of accords or treaties, I think is the way to do that. The technical community cannot do that alone, so the more that you can work with your organization. Today there was a meeting of a health emergencies committee at WHO, which is not the executive board of WHO, but is political representation. That's a relatively new committee. To the extent that you can influence that committee and its priorities and get them to lean into this work and to support the accord, I'd encourage you to do that. But the fact that you're working on the political level already, I think, is a huge benefit to this community, and you're such a strong proponent for it. I think, just to echo Nikki's points about the going too soon versus holding back, I did hear leaders in various parts of the U.S. hesitate, despite warnings from the top advisors in the country at the beginning of COVID. I heard people say things like, if we move too soon, we'll be accused of either fear-mongering or exaggerating, and that turns out to have been a terrible mistake. We maybe could have been more prepared in the March period of time if more people had leaned forward, and I think some people reflected on what happened with H1N1 and said, well, we were accused of overreacting. I don't think we can be worried about that in public health. We have to react when we see a signal, when doctors or nurses are dying in in a part of the world, or young people are falling ill and are on ventilators, that's a signal enough that something very serious may be happening. That does not usually happen. And all of us, I think, need to activate our governments and our networks to begin to prepare for the possibility of a major epidemic or a pandemic. So I would just encourage you to keep, I mean, the fact that you're asking that question means you're thinking about how to lean forward. So I'd encourage you to do that.
So one of the questions that I agree with what my colleague said, but one of the questions that was not addressed, understandably, there was only a few opportunities to, was the issue of the accessibility of interventions in the form of vaccines, therapeutics, and diagnostics for the developing world. So you have to start off with a fundamental principle that you have to believe in, and once you believe that principle, then you find a way to get there, as opposed to having obstacles determine what the principle is. So the principle is that we as a global community, particularly rich countries like the United States, have a moral responsibility to make sure that people don't die or suffer from a disease because of where they happen to be born. And that is something that we used as the principle of the PEPFAR program, because when we were trying to put the PEPFAR program together, people were saying, well, how can you possibly get drugs that are $28,000 a year to tens of millions of people in the developing world? That was looking at the problem the wrong way. The problem is we have a responsibility to do it, and how are we going to get there? And you can do it by any of a number of means. You don't have to destroy the pharmaceutical companies. You could do it by a combination of giving away free interventions such as vaccines and drugs. You can do it by two-tiered pricing. You can do it by any of a number of ways that you can do it, but you have to agree on the fundamental principle. And I think if we all agree on that principle, we're not going to have extraordinary disparities in the availability of life-saving interventions, because that's just not morally correct nor morally acceptable. That's my response to that.
And I think on that note, from Dr. Fauci and our colleagues, outstanding session. We've learned so much, and we have a long ways to go is one of the messages that I did hear. But I'd like to thank all of you for attending this conference and attending this plenary. Thank you very much.